Hello. So, hello everyone. Welcome to this third session of the day. Today, in this Clean Hospitals Digital Day, we had three sessions. We had a session organized by Gamma, and now you are in session called number 3, which is a panel discussion: how to promote sustainable innovation in the field of healthcare environmental hygiene. And we actually received several questions. But before we start looking at the questions, I would ask every one of the participants, the panelists, to present themselves. And I will start with Yolaine. Yolaine, can you present yourself, please?
Hello, thank you. So I'm Yolaine Carré, and I'm an infection and prevention nurse in the University Hospital of Bordeaux in France. And I'm really happy to be here to share with this panel.
Thank you very much, Yolaine. So the very west part of France. I will ask now Georgia to present herself, please.
Thank you. I'm Georgia Gon. I'm an assistant professor at the London School of Hygiene and Tropical Medicine. I'm an epidemiologist by background, but most of my work actually focuses on behavior change, and specifically in infection prevention and control in low resource settings. Really nice to be here.
Thank you very much. And as you can see, the gender balance in our session is well respected. And let me ask Stefan to introduce himself, please.
Hello to everyone. I'm Stéphane Pénary. I'm the founder and the CEO of Metal Skin Technologies, and which is a company that is specialized in biocidal surfaces and a pioneer in this area since 2013 now.
Thank you, Stefan. And last but not least, John, if I may ask you to present yourself, would it be necessary? I don't know, but John?
Good afternoon, everybody. Very necessary. My name is John Otter. I'm the Director of Infection Prevention Control at Guy's and St Thomas's NHS Foundation Trust in London. So that's a group of 5 hospitals across central London. I'm really excited about the next hour, looking forward to the discussions, and hope I can contribute. And thanks to everyone who submitted questions. I think they're excellent.
Thank you, John, and thank you for being with us. I know several of you are very busy with COVID. Unfortunately, the 5th wave is there. So we have to work on it. But thank you for taking this time with us together. Before we start, I just want to tell you that I just received a few minutes ago a message. That was a thank you message from 2 colleagues in Japan. So now in Japan, it's exactly 1 o'clock in the morning. So, and they are still with us. They were here at the beginning, but now it's 1 o'clock. So we will make them be awake, hopefully at 2 o'clock in Japan. So thank you very much and welcome to everybody. We have people from the USA, we have people from Mexico, we have people from Japan. It's a good sign of the way how much those type of exchanges are needed. So thank you to everyone who sent questions. I have here a list of questions that had been sent to us, and I will take some of the questions. I'm not sure we could do all of them, but ask the participant, the panelists, to answer to the questions. We'll start with one and another, and then share our expertise and our experience. Now, the first thing I would like to probably address is the first question would be, what is the next big thing in healthcare environmental hygiene? Can I start with you, Georgia?
Thank you. Well, I think it depends which angle you take. I think from perspective of low resource settings, I think the next big thing is actually to train people. There is a huge amount of lack of formal training in most low resource settings, of course, in the hospital environment. And I think the big thing there is actually making sure a basic level of training is available and targets the level of literacy and education of the people who are involved in cleaning. With regards to technology and thinking about technology, recently we've tested electrolyzed water as an alternative to chlorine-based bleach in Nigeria, doing a crossover design. And I think thinking about the sustainability lens has a lot of potential to actually be an innovative technology, not only for environmental hygiene, but for other applications in infection prevention and control. And happy to mention a little bit more about this. Thank you.
Thank you, Georgia. Stefan?
Well, unsurprisingly, I would say that surfaces are, of course, of great concern. Training is a key issue, of course, and everyone knows, I think, here among the panelists, that the cleaning protocols are linked with human being behaviors, and that sometimes there are flaws that's inherent to the human action in something. Biocidal surfaces can be a major step forward in that sense, that they provide a permanent and continuous action, whatever the human action is. Of course, they need to be clean. Of course, they need to be disinfected. They are just an added value to all these things. So I would say that for a long time, solutions that were present on the market were not efficient enough to have the attention of professionals like you. But today, with new standards that are coming, new ISO standards, for instance, we have the ability to prove that we are efficient in real life and in real operations. And therefore, I would say that this is something that should be integrated, as it provides additional safety on surfaces.
Thank you. Yolene?
Thank you. I totally agree with the need to more train health workers about environmental hygiene, but I also think that after 2 years of our pandemic, all health workers are tired, and I think that there is a need to raise alertness about environmental cleaning need and how important it is. And so I think that the first step is to raise alertness, and then to adapt our training to make a health worker can do the good process and understand that it's very important.
Thank you, Yolene. John?
Yeah, I found this question very difficult to answer, but very thought-provoking, in that I have two very big conflicting things in my mind as an answer to this question. Both of them share one key property. I think our general approach to environmental hygiene, which is to clean or disinfect at periodic moments to reduce risk, doesn't match the risk that we're trying to address. So the risk that we're trying to address is patients in a healthcare setting continuously shedding organisms, and yet we're doing kind of one-off interventions time and time again. We know they work, and we have to do them, of course. But I think the next big thing is technologies and approaches that provide a continuous level of reduction of that risk. So what I'm thinking of is things like antimicrobial surfaces that have some kind of biocidal activity or make a surface easier to clean, or air handling approaches that reduce the level of microorganisms in the air. And there's a dynamic interplay between organisms in the air and on surfaces. I'm finding it very difficult to choose between them. I will if I have to, but I'm going to say the next big thing is both of those things.
Excellent. Thank you very much, John. We all see how much this question is actually difficult to answer, and we also see the need for a sort of a multi-pronged and multimodal approach to actually succeed, because it's not a thing that we could decide like this. It's something we need to all work on. So excellent, and thank you very much. I'm pretty sure that people will really appreciate. I have another question I wanted to address. One of the questions is there any innovation that can replace manual cleaning? Any innovation that can replace manual cleaning? I'll let you think about it. And maybe Stefan, would you like to start answering?
Well, I would say that imagining this kind of thing is being a fool. You cannot replace manual cleaning. my personal perception of this is that manual cleaning provide at the same time visual inspection. I mean, when you clean a surface, I'm not a specialist of this, but as I know from what people do in this area, when you clean a surface, you check and you double check, and you have a visual control that give a certain level of quality. We all know that this is maybe not perfect, but leaving that to a fully automated thing would be, to my mind, dangerous. And believing that, for instance, a biodiesel surface could discard the cleaning process would be also being a fool. I mean, because a surface to be active needs to be clean, and first you clean and then you disinfect. I mean, you taught me that, Professor Pite. So, in addition, well, replace manual cleaning. I think it doesn't make sense in terms of a global prevention of the risk, to me.
Thank you, Yolan. I guess it's a dream, right?
Yeah, probably a dream for all health workers, but I think, like Stefan, that we couldn't replace manual cleaning because I agree with the fact that it's a way for us to check and to see if there is a problem, but it's also the first step of more of disinfection protocol. We couldn't disinfect if it's not clean. So for many reasons, we couldn't replace manual cleaning, I think.
Georgia, any additional comment?
I think what I'm thinking about is that where it matters the most, it's the hardest, which is the patient zone. And where the patient zone is where you want both cleaning and, of course, disinfection at times. And you want to make sure that the patient is safe at the same time. So the products you use are safe for the patient. So I think that's the real conundrum. Can you achieve a clean patient zone and disinfection within the patient zone in a way that is safe for the patient? For the context of low resource settings, that's incredibly hard, especially because you have overcrowded environments. So evacuating a space, it's hard enough as it is. So I think the setting matters a lot when you're thinking about this as well. So I don't have an answer, but I have a few considerations to bring to the table.
Thank you. And John, sorry, you are the last one to speak again. Most difficult position, but tell us.
So I don't know the answer to that question. I think it's unlikely that we will replace altogether the need for manual cleaning in our hospitals, especially. But let's be visionary. Let's imagine a cleaning robot type approach, a robotic automated approach to room cleaning. It's not impossible over the coming years with the way robotics and AI is developing. I can have a vacuum cleaner that automatically vacuums my house. I could have a lawnmower that automatically cleans my lawn. So why not a robot to automatically clean my hospital room with a focus on those high touch services? So not yet, but maybe in the future. And I think we can reduce the reliance on manual methods with an adoption of some technologies. But right now we can't completely remove the need for good, thorough manual cleaning.
Thank you very much, John. So it's we have a good consensus regarding the importance of manual cleaning, but we need to be open to innovations, as John said. We have seen in Japan some of those robots working interestingly and intelligently. There is a future, and I think that it also tells you that there is a lot to do in the field of environmental hygiene. Now, another very interesting question we received is, and I will start with you, John. Is there the question is what are the elements that affect the sustainability of an innovation? The element that affect the sustainability of an innovation.
I suppose the first thing is it depends what we mean by sustainability. So are we thinking about how much this innovation will be adopted and whether it will be effectively sustained as an intervention in a hospital, which is sustainability in a sense? Or are we talking about environmental sustainability, which is obviously equally important, but a very different question? if I can comment
we'll
on,
first answer to the question sustainability over time, and then we'll probably discuss about environmental issues.
Okay, great. So let's think about how we can make an innovation stick. I think the first thing is to have good evidence that it works, and the evidence for environmental hygiene generally as a space has come on massively in the past 10 or 15 years, to the extent that I think we now have better evidence for environmental interventions in infection control than pretty much any other interventions in infection control. And I'd include some of the tried and tested methods that we rely on day to day. And so I think we have good evidence, but obviously we need evidence for the specific intervention. And that requires investment of intellectual capital, but also of actual finances to do the studies to provide the evidence that it really works. Once you've done that from an organizational point of view, I think there will be some adaptation that will oil the wheels of that adoption, and not being dead set on a particular way of doing things, but recognizing there will be local variation in a way that an innovation is adopted. And that will help us to win the hearts and minds of the frontline staff that we'll need if an innovative intervention is to be sustained.
Thank you, John. Georgia?
So maybe I'll take the environmental sustainability. So we cover both. I think it's environmental sustainability is a key concern going ahead. I mean, given the current climate we're in, and I think especially when we're thinking, for example, a country like the UK is leading towards carbon zero emissions, and especially thinking about low resource settings that are constantly changing and constantly adopting, they have a great opportunity now to think about the technologies that are more sustainable, that are potentially created in a more sustainable way, that have less emissions, and maybe target several components of infection prevention at once. So what I would recommend is to make environmental sustainability a key criteria for adopting new technologies, whatever they are. Thank you.
Excellent, thank you. Yolene?
I think that, as John said, there is some local concern. And so I think for the sustainability of innovation, it's important to adapt it to the needs and the resource of the establishment we want to implement it. So it's the first steps to check what is the need, what's the resource. And so implementation need also a multimodal approach to make it sustainable. I think it's a multimodal approach adapted to the local situation.
Thank you, Stefan.
Well, I have I have a case study in my company that is how to make it sustainable, in a sense that how our innovation would last and would be adopted. So first of all, of course, science is a key point. Proof of concept is essential prior to any development, and then afterwards, in order to have the power to develop this and to propose that to healthcare facilities, you need patents. You need patents to build products. You need patents to develop. So intellectual property is key to also, but also convince professionals that solution is an added value for them. So standards are key also, and we have worked a lot around this, because it is absolutely necessary for an innovation to be implemented and developed in a healthcare facility, that it can be benchmarked, it can be assessed, it can be evaluated prior to its implementation. I mean, you cannot always test along and on and on. Therefore, standards also are a key issue. And so if we compile all these three elements, you need a science, so proof of evidence. You need a good standard that assesses the efficacy, and then you need a patent in order to develop and to make different uses and to adapt your technology to the needs of each specific healthcare facility.
Thank you. I would like to submit to all of you, speaking of course, long-term sustainability in a hospital, what is important is definitively that healthcare workers would sort of be happy with the methods, or we could help them by automated systems and so on. One thing I would like all of us to remember is that when I was a junior in this hospital, we were using glutaraldehyde, glutaraldehyde for many things, for the disinfection of instrument and so on. I would never have imagined that my hospital would become one day glutaraldehyde free. So I think that today we really need to look at everything that we are using and go in that direction for environmental sustainability, because that's our mission, to go in that direction. And what was totally impossible, or would seem totally impossible, I remember at the beginning when we had to suppress glutaraldehyde, I mean, people would say, it's impossible, you will never be able to do it. We need this product. And today we don't use it for years now. So I think that this is a great challenge, but this is a very, very key and important challenge. And in healthcare, we should certainly try to show the way. And it's interesting to see that some of the question you see on the chat, actually, how can question number 17, how can manufacturers start working on sustainable solutions when the future is unpredictable? I think it's a challenging question, but that's our responsibility, all of us, users and companies and innovators, to carry this message and this mission in order to really think how much we could be a model for once in such a domain. I would propose to go to a next question. One of the next question we had is, what are the pros and cons of automated disinfection? Pros and cons of automated disinfection. Georgia, would you like to start?
I think it's a bit hard. Disinfecting what? I think that would be my questions. I think there might be some different pros and cons there. I think again, I'm sorry, but I'm very focused on a low risk setting type of context where I usually work, and automation, any kind of automation comes with maintenance, comes with personnel associated with it, comes with extra training. So one of the cons in that type of setting is making sure that all of the chain coming onto automation, so whoever is responsible for that is actually trained and they have the actual resources to maintain that kind of system. So that would be my consideration. If you have an automation, making sure that you have all of the apparatus around it to make sure that it actually works. So not burdening extra the system itself. Thank you.
Thank you. Yolene, would you like to add some comments?
I think I agree it's a difficult question, but I think it's for some, we have some automated disinfection for some medical device, and it's really easy, and it could help health workers to do something else when the disinfection go on. So it could be very interesting, but it could also be difficult if you have to be trained to use it, and so it's the same problem. So that's not perfect, has all the proposition.
Thank you, Stefan.
Well, I have no specific proficiency in this area, so this is an even more difficult question for me to answer.
Don't worry.
But I would go with Yolene, saying that any automated process needs at a certain level people to look after it, because fortunately or unfortunately, but I would say fortunately, human being is key issue. And also I have seen some technologies working where well, they could not that efficient if people were. You are not working in empty spaces. You are working in crowded spaces. So our automated disinfection process in the global area, like a corridor or waiting room, needs people to get out of room. So this is something very difficult to adapt, I believe. But again, I'm not a specialist of this.
Yeah. Now, John would be able to make a perfect summary of what has been said and list the advantage, disadvantage.
Well, Didier, that's very generous of you. Again, I'm not sure that's necessarily true. I think the fundamental problem or challenge that you're trying to solve with automating the room disinfection process, or in fact automating any process really, is to remove that unwarranted variation that's related to the human being doing the doing. So we know that actually manual disinfection can be perfect. It can obliterate every organism on every surface, but the problem is it doesn't do it every time. So I think we're offering that ability to remove that unwanted variation by automating the process. There's also a sub part of that's not quite true, in the automated room disinfection systems offer the potential for a higher level of disinfection than you could ever get with an automated process. But I think the core reason for doing it is to take away that variation. And on the flip side, you pay for that with operational challenges. It takes longer. You have to clean off the visible dirt first. You have to vacate the room with most of the effective technologies. So I would see that as the primary advantage and disadvantage. I'm personally convinced now by the evidence that if you could do an automated room disinfection after every discharge and before every admission, you would. And in some circumstances, you probably should. But the reality is that we can't, even in a well-funded high income setting, we can't. In a low middle income setting, it's even more challenging. So then it's about rationalizing our resources and putting these kinds of systems in a focused way where we're going to get most impact on reduced transmission.
Thank you, John. There was a related, thank you for a very nice summary. There was a related question that we received regarding automated disinfection. And the question related was, can automated disinfection encourage a false sense of security? So have you witnessed it? Or maybe I will come back to you, John. Have you witnessed this type of situation?
Yeah, it's a risk. It's a real risk. And I think it can be managed effectively so that it's not a real risk if it's done well. And I don't think it's a risk that's unique to automated room disinfection systems either. I think it's a risk that can occur with any new technology and innovation. People can over rely on it, and it can be seen as the silver bullet to solve all woes, whereas actually it's part of the jigsaw, and it needs to be seen as part of the wider multimodal approach that we need to take to reduce the risk of transmission and maximize patient safety.
Yeah, I fully agree. I guess everybody would agree with this answer. And we had this beautiful first session this afternoon with the REACH study summarized by two of our colleagues from Australia. It was pretty impressive. And again, this necessity for a multimodal strategy is really telling you how much we need to sort of mobilize the entire institution behind the action. If you agree, I would like to move to one of the question that was submitted, like the question number 19 on the chat. I read it for everyone. Many hospitals have no recycling waste streams, partly because of the risk that waste may be placed into the wrong stream. Have you any suggestions on as how this could be overcome? So I repeat, have you any suggestion as to how this could be overcome? So maybe Yolene, you could provide an answer to that in your expertise.
Yes, yes, I don't know, but I will try. I think that we all have environmental interrogation, and it's more and more, and also in environmental cleaning. So I think it's depend on establishment. For example, I was in a very big structure, so it would be very difficult for us to implement recycling waste, because we don't have the capacity to create a new I don't know the word, a new
New
chain
facility.
for
Yeah.
the recycling. You understand?
Yeah, we understand.
And,
A new
and
chain and transit chain for
yes,
the recycling.
and
Yes,
so
absolutely.
maybe if you want today, it will be very difficult to recycling this type of device, and so maybe in the future. But I think it's directly linked to the capacity of the hospital, depending
Yeah.
on the organization.
The logistics and organization.
Mm.
Stefan, any
Yes.
comment?
Well, in
Stefan?
this matter, I really have no expertise, so I leave the floor to the other panelists
Okay.
that probably have more input.
So we'll ask John, and then Georgia will speak about low-income country. But John?
Yeah, so I think we can make good progress. I think it'll be baby steps. I think we can move away from the traditional incineration versus landfill approach and think about somewhere in between. I also think that we should be looking at more sustainable approaches to waste, not least developing and designing products that are designed to be reused where they've traditionally been discarded and incinerated. One example is reusable sharps containers. Reusable sharps containers, not reusable sharps themselves, obviously. There's some innovation there that requires to be tested and evaluated. The other thing that's on lots of people's radars is personal protective equipment as well, and whether we can make some strides in reducing our plastic waste related to PPE. I think we can. We need to think about how that IPC risk is managed and whether organizations are prepared to increase their level of risk tolerance for cross transmission in hospitals in order to develop a more sustainable future. And I think the answer to that should be yes, to a degree.
Thank you. Georgia, with the flavor of low-income countries you love so much, as we do, but you have great expertise in this area of the world.
Thank you very much. Well, I think that the waste disposal systems in many low resource settings is not ideal, and there is a lot of room for improvement. But that kind of also makes us think that there is also room for switching to alternatives that might be more sustainable in the long run. So you can think outside of the box and not necessarily follow all the steps that some high-income countries have followed. So that would be one thing. Another thing to mention is that related specifically to waste residue from cleaning fluids is to think, can we switch to cleaning fluids that have less harmful waste residue that goes into water waste. So that's one thing to think about. And one recently I've been involved with testing electrolyzed water, and which actually might be helpful for delicate equipment that cannot be sterilized. And you know, it's not good to use chlorine on, and it might be a good middle ground to try and reuse some of that perhaps protective equipment or some delicate equipment that cannot be disinfected otherwise. So thinking openly about alternative technologies that can help us with that. Thank you.
Thank you. Yeah, excellent. I think that this is really telling you how much we can adapt to the different situation and how much it's important. Let's take again one of the questions that is on the chat, which is going a little bit in another direction. Disposable plastic-based wipes are getting a lot of bad press. Are there any sustainable/recyclable solutions that you could foresee? So the idea is disposable plastic-based wipes are getting a lot of bad press. So comments, maybe we can start with you, Yolaine. Any experience in Bordeaux about disposable plastic-based wipes?
It's for yes. I just need to be sure of the traduction. Plastic-based wipes. It's
Oui, c'est simplement les outils pour imprégner des surfaces qui sont en plastique.
Yes.
Qui sont jetés ensuite.
Oui. Um, uh, it's a very good question, and it's on the same way that the first question. It's about our ability to have recyclable solution, and so I think we try to go on with a more recyclable device and more recyclable solution, but we are a little bit we have to adapt with our possibility, and I'm not a good recyclable one. I'm sorry.
No worry, Yolene. No, I don't know if Stefan has a comment.
Or not specifically about this topic in particular, but I would say that plastic is recyclable normally, but I don't know how these products are fabricated, processed. But well, I would say, of course, that the more recyclable the thing is, I mean, we have a lot of concern with our technology, for instance, to have the possibility to recycle the material we coat with indoors and everything. So this is very important. But again, this has a cost. And what is possible and what is not at that moment, I mean, it's very difficult to assess. I mean, I don't know.
Thank you, John. John, in the UK, and how do you see the aspect more widely?
Yeah, it's difficult, isn't it? My mind is split in two here. I love these kind of wipes, and I also hate them. I love them because I think they improve patient safety and they bring effective disinfection solutions right to the point of care in a way that conventional approaches don't. And I really think they work. I hate them because they're plastic and they contribute to plastic waste that might end up in the belly of a dolphin somewhere in the world. And that feels very out of step with the way things are going. Right now, I'm not aware of any good recyclable and effective basal materials to make a really good disinfectant wipe for use in healthcare that is fully recyclable. So if there was, I'd snap it up, and my willingness to pay would be very high, and I'd be lobbying the organization to pay whatever it costs to bring them in. But I think it should be an R&D focus for industry. And part of the reason for this group, the Clean Hospitals Group, is to bring together our expertise as professionals, but also industrial partners like Stefan to bring in their expertise too. And this feels like one of the key issues that we can co-develop solutions to.
Thank you, John. And Georgia, seeing a little bit from the low economy part of the world.
Yeah, I mean, I couldn't agree more with John. He summarized it very well. We don't, in most, I mean, I would say many of the settings where I work, we don't have that issue because they just are not existent. And many times I wish they were, obviously, because they can support behavior change in a way that many other things can't, because it's so much easier to clean if you have wipes. And it's so much harder if you have to have a structure where you have reusable cloths, you have to wash them, you have to hang them properly, you have to make sure that they dry properly, and so on. However, I do think that it's an issue also for private and public partnerships, perhaps as well, of finding innovative solution. Maybe also thinking out of my head in places where you want to reuse products, for example, reuse cloth. Is there like a public-private partnership that can take that on? You can just like kind of outsource them outside of the hospital, clean them up, and then they bring them back in, and that also becomes an economic opportunity in some settings. Thanks a lot.
Yeah, I thank you very much, Georgia. I think you're right mentioning different models that could make things reusable without harming, and that's things that I fully agree. We need to work together and work with the industry to sort of have new innovations in this field, and creating jobs and interactions could really help. What I propose now is to take another very quick question and quick answer, like in the chat. Do you believe in fumigation of air inside hospital or outside during epidemics, pandemics of an airborne or droplet infection? Yolene, would you like to start answering?
Yes, in France, it's not fumigation, it's of of air inside hospital or outside with epidemics, it's not practice that we do. So I'm not used to, it's not easy for me to answer to these questions, but
you are not using it in your daily practice, correct?
No, and
Yeah.
and so we don't use it, and with COVID precaution and standard precaution, we deal with it. So I think that it works.
Okay, thank you, Stefan.
Well, here again, I'm not a specialist of air treatment, but I don't see why this could not be combined with other practices, with other methods, other technologies, and make it work out. I don't know. I'm not a specialist, but again, as an innovator, I mean, why wouldn't it work? But is it possible to do? I have no clue about that. Sorry.
Thanks, Stefan. Georgia, any experience or any comment?
No, unfortunately, no experience on this, but really thinking hard, how does that fit with patient flow, especially in some overcrowded environments again. So that's a big thing for me to think about. Thank you.
Thank you. And John, and I will ask you, John, are you using it in your institution? How do you see it today?
So I prefer to use the term air disinfection, because I think air fumigation makes me think of chemicals in the air. And I think there's a number of different approaches we can take to disinfect the air, that is to reduce the level of microorganisms to what we consider a safe level. And that could be through filtration, it could be through physical means like UV, or it could be through chemical means that like hydrogen peroxide, for example, would all have an effect. So I have some hands-on experience with these kinds of systems in the context of theatres and reducing the risk of Mycobacterium chimera during cardiothoracic surgery. And actually, in that setting, it was incredibly effective in reducing the level of microbial contamination of the air. But the problem that we have before these kind of technologies can be implemented really widely is that evidence gap, that we don't have really good outcomes. We don't have evidence to say that if we reduce that level of contamination in the air, that will translate into reduced transmission. I think it will. And the respiratory virus pandemic has certainly taken this whole sphere of innovations forward step to the point where we, as a profession, are now considering putting this kind of unit into an area where ventilation is poor as a mitigation. So we're not saying we know this works, but we are saying this is one of the ways that we're trying to reduce transmission in an imperfect scenario.
Thank you, John. In our institution, we to answer to the person who asked about fumigation by itself, we used to use it in our institution. Today, we don't use it anymore at all, except in a very, very specific situation in laboratory where we have like fungal infections. Now, speaking of air biodecontamination, it's another issue like just John discussed it. Thank you very much for these answers. We got a very interesting question now also to try to answer to our colleagues listening to us, and there are many following us. Are there any innovation when it comes to implementation or to the human component of environmental healthcare cleaning, if you like? So I would start with Yolene, probably. Any innovation when it comes to implementation or to the human component of healthcare environmental hygiene?
If I think to human component, I think that innovation, we heard it like implement a new device or new technique. But if you think on a human way, we could reorganize the task, because generally on hospital settings, tasks are really separate depending on the type of professional. And so it could be interesting to reorganize the task and to say that for the environmental cleaning of the surfaces near to the patient, it should not be only one type of person who could do this. It could be and a nurse or help nurse or anyway, depending on disponibility. And I don't know if it's the same in other countries, but in France, tasks are really, it's like nurses do this, nurses have do other things. And so maybe it could be recognized differently to optimize cleaning.
Thank you, Yolaine. Stefan?
Well, in terms of human components, we talk, if I understood well the question, about training, information, and access to healthcare workers to the technology and their use. There is a great innovation. It's called clean hospitals. Because I have the chance to be part of it, and I have the chance to participate to work groups, and that's precisely what we are talking about. We're talking about how to have these technological inputs, as to have this innovation, this product that already exists, and how to put them into the great system of infection prevention with humans, and how these humans can cooperate correctly together. And well, I don't know if it is necessary to have specialized worker for a certain task or not. This is not my job. But what I understand is that innovation will come through training, continuous training in all matters. The problem today is that I realize, for instance, for surfaces, again, this is my field of competence. The knowledge is very low. So that's why I rely on clean hospitals to talk about that, and that's what we're doing right now. And I'm very pleased, and I thank you very much, because people have to know what is a real biocidal surface and what can they do with that and what we cannot do. And the great improvement and the great innovation is as for the human component at this stage to me.
Thank you, Georgia.
Thank you. So I think, like, for any type of behavior changes in this type of context, I think we need to think about how this behavior actually gets done. It's something that has to be repeated over and over again during the course of the day. It's not something you do as a one-off. It's a repeated behavior that needs to be sustained over time. Now, I think dependently on the context, I think some really small things can work very well to sustain that behavior. So, for example, thanks to actually Gamma Healthcare, we've been using gel dots in trying to improve behavior in 3 Tanzanian hospitals, and actually providing that feedback and checking on their performance on a weekly basis had a huge, I guess, in a way, Hawthorne effect, right? Because providing that feedback and establishing that feedback loop, even though simple and something that other areas of infection prevention control, like hand hygiene, have been doing for a long time, was essential in that context. So I would say some of these small things can be really, really useful, but I would also emphasize how much the context-specific barriers are important. So if you're in a hospital in London, it's very different if you're in a hospital in Cambodia. There is one training package that we've been testing for Teach Clean that now will be adopted by the WHO. And in a way, I mean, it's impossible to extrapolate one of these elements to be most important in that training. But definitely a multimodal strategy and thinking about in a participatory way, especially when you're thinking about an audience that has low education level, it's fundamental. You're training professionals, you're training people who are already on the job, and you need to catalyze that learning and bring it into that education. So I think there is no easy answer, unfortunately, but thanks a lot.
Thank you, John.
Yeah, actually, I don't have much to add to that. I think all the points I was going to make have been covered. I just think that any way we can get instantaneous, meaningful feedback to staff in a language that they can understand, if you see what I mean, it is going to be a way to drive improved human factors in this area.
Thank you. We received, I fully agree with what has been said. It's a major challenge. We need to continue to work and see how this multimodal strategy could be best implemented. And of course, they should always be adapted because of the institution, the resources, the culture, the tools available, the product that are used in one country, not in another, and the way the institution is supporting. So in this regard, I would like to ask you all the question. I mean, what have been your difficulties at implementing an innovation that makes sense in your or several institutions you have been working with in the past, let's say 3-5 years? So maybe I will ask Yolene to start. Yolene, did you have in hand something you wanted to introduce that was a revolution for you and didn't work for one or another reason? Tell us.
I thinking it's sometimes it's the problem is the training and the adhesion of the team, and it's depend on the difficulties to use the device or the process. And I don't have yeah, I don't have a clear example to sit to you, but I know that when we have difficulties is when we change the process, and when it's more complicated than the last one. And so we have to justify, we have to make them understand that it's important, and it's sometime when we had some step in the disinfection process, sorry. So yes, it's the complexity of the process who make it difficult.
Thank you. John?
So I have a story, but how long have you got? I mean, we've got 9 minutes left, so I'll try and be really
9
quick.
minutes. Go ahead. You know how to tell stories.
I think it's a good example because I have a background working in the private sector with a company that developed automated room disinfection systems, and it's sort of how I began my career in IPC, and that journey was fascinating and taught me a lot. And there's things I do differently. I think at the start of that journey there was a misunderstanding of what was required from the company's point of view. They had the energy, they had the product, they had some money. They didn't have the expertise to say this is the research we need to invest in. So there were lots of blind alleys that went down that generated data that wasn't meaningful in terms of technology adoption. So I think this kind of interaction between industry and professionals working in the field can help to direct the research into the most meaningful direction, which is in everybody's benefit, to develop innovation to support best practice in terms of environmental hygiene. And the other thing is time. It just takes time for people to come around to ideas. Even when the evidence is there's a great deal of inertia that needs to be overcome, even when everything is in place. So it requires quite a lot of patience.
Nice comments, nice story. Thank you, Stefan.
Well, I have been facing this for years, this kind of problem of implementation of our innovation. I'm going to tell a story just like John did. At the very beginning, the people were looking at me. I mean, I'm talking about the procurement department in an hospital were looking at me, and they say, okay, if we use a biocidal surface, this would maybe be an acknowledgement of the fact that we do not clean correctly. That was kind of argument. I mean, the people, well, maybe specific to France, but people are quite reluctant to change their habits, to change the protocols they have. And in some areas and in some cases, people are sure that the protocol they use is a perfect one, and they don't want to change. So this resistance to change is very difficult to fight against. So as John said, you fight that with science. You find that you fight with evidence. But then you have another argument. That is, am I obliged to do that? For instance, is my Minister of Health is asking me to do that? No. Does this criteria enter into my average record at the end of the year that will give me more money from the public? All these questions I did. In the end, the answer is no, I don't need your technology, so I do not see an interest for me as a manager of the hospital to do that. So again, you come back with science, you come back with standard, and you try to convince, and you try to move forward in order to prove that combined with our technology, what you bring is something important and something that can have an added value. But again, this is patience, this is resilience of every day, and you have to trust in your technology, and if not, you die. So that's a very difficult path. And but time is working with good solutions. That's my belief anyway. And step by step, we are trying to convince and to make that things happen.
Thank you, Stefan. Georgia?
Thank you very much. I think one of the challenges that I faced in the past is allow me the very broad term culture. Environmental hygiene, I would say it's not top priority for many hospitals or for many settings, and not only in low resource countries or anything like that. So I think we're dealing with a cadre who is staff who cleans, who is not necessarily a priority for everybody. And it matters. Are they contracted out? Are they not? Do they have incentives? How much are they paid? Do they have holidays? So the human factor does still remain a challenge. And to me, that's where I think we need to think innovatively. Maybe we need to think about how we can change this culture. And of course, this is what this group is all about. So I would say this is one. And the other challenge I faced, I think, it's the lack of rigorous design in the field of environmental hygiene research. And I think that can make a huge difference when you're trying to make a cost effectiveness case to the local government, for example. So I think one thing that we've been trying to improve on also as a group is to try and invest in that rigorous design. Like now we're trying to start a randomized trial in Cambodia, trying to test environmental hygiene intervention. But I think it's really hard, and until we have that evidence, and especially in relation to cost effectiveness, I think it's going to remain a challenge to convince local governments to act upon it. Thank you.
Thank you very much. We have 3 minutes left, so I will take a last question before, or just before the last, and then we have a short answer. But last question to all of you before the very last. What are the key components of successful hospital environmental hygiene programs? If I need to ask you 3 keywords, or we start with Stefan. 3 keywords.
Oh well, John, I hope my answer will be good. I would say clear evaluation of the process, maximum control, continuous control, and the will to change if it is not correct.
Okay, Georgia.
Can you repeat the task, please? I missed the instructions.
3 key parameters for successful hospital environmental hygiene program.
So implementation program. Yeah.
Yep.
Yeah. So yeah, evaluation and feedback, stakeholder engagement across all stakeholders, everybody, and yeah, maybe change of culture. I'll put it to that. These are pending. I'm happy to revise them as I go along.
Okay, Yolene.
Yes, 3 words is just not easy. No, I would say that there's different step, and before the implementation, I keep on saying it's important to evaluate needs and resource. And for the implementation, all the strategy of multimodal strategy is just a word, but it's many things. So it works.
Very good, John.
Yeah, this was a good one to get last. Funding, leadership, innovation.
Great. Thank you very much. And last question to all of you. The question that we receive is there an international prize for innovation in healthcare environmental hygiene? As far as you know, Stefan.
Professor Pité, it's time for Clean Hospital to create it. To my knowledge, to my knowledge, Vernon.
Okay, Yolene?
I'm sorry if I made a mistake, but I think no.
No? Okay, well, Georgia?
Not that I know of.
Not that you know. And John, do you know anything?
No, but there should be.
No? Okay, it should be. So yeah, it was a good question that we received, and that's a nice conclusion of our session. It's time to close, and I would like to thank you very, very, very much, the 4 panelists for this interactive discussion. I would like to thank everyone for following the discussion, sending so many questions. There, of course, are some questions left that maybe for the next time, for the next Clean Hospitals Digital Day. I hope everybody enjoyed. I'm pretty sure our Japanese colleagues and friends are pretty tired. It's now 2 o'clock in the morning in Japan. So I wish you a very nice evening for those who have an evening, or day for those in the USA, and good night to our Japanese and Australian friends. Thank you very much to all of you for participating to our event, and thank you for being part of the Clean Hospitals initiative. Thank you all.
Thank you.
Thank you.
Bye-bye.